Good afternoon, everybody, and welcome to QPS TalkTime. Today we have a very special guest, Dr. Seán Paul Teeling, and we're here today to talk about the person-centered Lean Six Sigma model. Not two things that you'd normally see in the same sentence. When you're thinking about Lean, a lot of people don't think about person-centeredness, so it promises to be a really interesting session. So just as we're waiting for a few people to join us, we know that this is people's lunchtime usually, so you might be just getting the sandwich ready or getting the cup of tea. And just while we're waiting for people to come on, just to say that there are a lot of QPS resources that are there at the moment to support you in your work. You can join the Q community. So whatever QPS topic you're interested in at the moment, sometimes it can be helpful when you're in that space to have a broader community to tap into. So the Q community is there. You can become a member. It's free to join. And there are lots of different subgroups there. So whether it's change, whether it's pressure ulcers, whether it's full, whatever your topic of interest is. And some of you, like myself, might be involved in many different groups. But there's a whole host of resources that are there to support you. Just to say as well, our March edition for Quality and Patient Safety Matters is now available. And just it's a quarterly newsletter that's there. And to say as well to people that if you have thoughts, ideas, or content that you're interested in seeing in our next edition, which will be released in early July, let us know. You can drop us an email, or there's a short survey that you can fill in just to let us know what are your thoughts on it. And particularly if there's something you're doing in your service that you'd love to share with a broader audience, come back to us and let us know. There's also the prospectus of quality and patient safety, education and learning. And that particular prospectus has a whole host of training programs that are there. Again, they're all free, and some of them online and some of them are in person. But that's available on our website, so you can have a look at that if you're looking to increase or develop your skills, further develop your skills in quality and patient safety. And the other thing to say is our podcast series, Walk and Talk Improvement. So we've new episodes coming out every month there. And we'll talk a little bit later on about the two for sepsis, which are our most recent ones. We're really looking forward to the upcoming episode with Margaret Murphy, who's a patient partner, and we're hoping to release that in April. So they're all available wherever you get your podcasts. If you're following us today, you'll see at QPS TalkTime on Twitter. The at QPS TalkTime or at National QPS is the main National Quality and Patient Safety Directorate. So just in terms of the session today, we're going to be exploring how you can move away from a checklist and tools-based approach to improvement. And sometimes the checklist and tools can be very important, but it's sometimes a lot broader when you're dealing with people. We'll gain an insight into the differences between Lean Six Sigma methodologies and a person-centered approach to care. And then learning how to develop meaningful metrics that move away from a narrow range of volume-based metrics, which are not necessarily the facilitators of person-centeredness. And obviously exploring, well, what is Lean Six Sigma person-centeredness? So I'm delighted just to introduce our guest, who is Dr. Seán Paul Teeling, and he's a lecturer and a practitioner in process improvement in UCD Health Systems, with research and teaching grounded in systems thinking. His work emphasizes the real-world application and implications for personal and professional practice of concepts, including Lean, Six Sigma, person-centered cultures, and collaborative practice. And he holds Teaching Excellence Awards at both college and university level, and he's a UCD Fellow in Teaching and Academic Development. And I've just learned he's a wonderful singer. So there's lots of things that we don't know about Seán, and hopefully today's session will be able to tell us a little bit more about. And I'm Juanita Guidra, and I'm a Programme Manager for Staff Engagement for Quality with the National Quality and Patient Safety Directorate. So I'm going to pass over to Seán Paul now, and just thank you so much for joining us today. We're really looking forward to the session.
Thanks very much, Juanita. I really appreciate that. And look, just to say up front, thanks very much to Juanita and the entire team for having me. I'm delighted for the opportunity, and thank you, everybody. I know you're all on your lunch break. I know I'm going to talk about that, about how precious time is, and just thank my colleagues in the Mater, Lean Academy, and Queen Margaret University, and Mary Day and Beacon, and our 12 study sites who've worked with us in Ireland and then internationally as well on this model. And obviously, I'd like to really dedicate today to Professor Jan Jung, who many of you will know, who was my PhD supervisor, who unfortunately passed away a number of years ago now, and who was very integral to this research. So really, I'd just like to give her a shout out today. I know she's very proud of the work we're doing, and I'm really thinking of her today as well. So moving on then, I suppose just to give a bit of context, really, and you're all aware of this because you're all living the dream, so to speak. So really, one of the biggest healthcare challenges globally is equitable and fair access to quality care, and not just care, but to quality care. And there's disparities in access to healthcare everywhere, really, you know, whether it's income or location or ethnicity, gender. Internationally, it's a problem. The costs of care continue to rise worldwide. access to necessary medical care and equipment continues to rise worldwide. And these too can lead to delays in getting to good care. There's, demographic shifts. We've an older population who obviously will have more chronic conditions that obviously require more input and well deserved and required input, but will have their own challenges for the health system as well. And the pandemic, I think, really underlined, and even influenza, how we can, the strain that can put on the system. And we've all been through the pandemic. We've all worked and lived with it in the last couple of years. And then, of course, there's huge workforce shortages internationally again, not just talking about Ireland, which is a major issue. Whether it's doctors, nurses, HCPs, or any of the staff grades across the hospital, not even clinically facing. It really limits the capacity of us to do our jobs to deliver timely and effective care. And then, of course, these can vary internationally, but those problems are existing right across the world. And then even with technological advances, which are fantastic, and all the changes that are coming, they require a lot of staff confidence and I suppose competence and confidence in them as well to get up to speed with new technologies. I mean, even going back to when I was an anaesthetic nurse many years ago in the 1990s in Beaumont, I remember coming back off holidays and they brought in new anaesthetic machines, and I was starting nights that week. And I had to go in and work all day before I went on nights that night, because we were doing like retrieval and neurosurgery and everything. And I thought, I have to be competent in those. But I had a week of nights where I literally didn't sleep all day, as well as working all night, because I was so worried. So, new technology brings worries and challenges for staff as well. So that's the context, just a bit of the context we're working in. So moving on from that, then, I suppose there's the response from the health services has been to adopt and to develop process improvement methodologies, which many of you are familiar with, whether it's the Model for Improvement or Lean or Six Sigma or Lean Six Sigma or Agile or the Project Management Book of Knowledge or Prince 2. There's many of them out there. And I suppose there's many varying ones that we use, but ultimately at the end of the day, to try to make the quality of care we deliver better. So moving on then, I suppose Lean and Six Sigma are two of the most popular internationally, used to varying degrees. They can be used separately or used together. And there's a wide body, before we started this work about 7 years ago, there was a wide body of research on Lean and Six Sigma and their impact on effectiveness and efficiency and on outcomes. But there was very little known about the influence of them on person-centered care or cultures, or could you practice both together, or what would they look like, and what are the relationships between them? So it was really important for us to try and focus on those. So if we move on, we can see that Lean is Six Sigma is a hybrid of Lean and Six Sigma process improvement methodologies. They have a strong focus on the patient, the employee, management, support, and teamwork. So just to give you an example of that, now this isn't animated, but just on this slide here, this is Betty. She's 83 years old. She fractured her hip a number of years ago. She fell over. And if you look at all those circles going around, they're all of the touch points where different members of staff from the moment she arrives in the hospital touch Betty's journey. So from being registered to being seen by the RNs and getting her ECGs done, her bloods taken, and then being seen by the ED team, and then having her radiology diagnostics, and then the orthopedic team see her, and then there's all the other people looking after her in the department, and it's off to theatre, which are anesthetic nurses and circulation nurses, etc., etc. And then obviously her HCP team are spending a lot of time getting her rehabilitation, particularly OT and physio. And then there's the whole piece of all the other services that look after her, like her meals, cleaning her bed space, and everything like that. And then there's the interface to get her discharged out to the community, her OT assessment for home, the adaptations to the house to get her out. So various people touch Betty's journey at different points. In fact, 118 people touched her journey. I know this because although she's passed away now, Betty was my mother, so I was able to follow her entire journey because I actually worked in the hospital where she was being treated at the time. And unfortunately, we've lost her now, but very much with us, like Jan. So 118 people. Some people only touched her, like the people who registered her in the ED only touched her briefly. Some people spent more time with her. But the key point is that value add occurs when somebody gets their hands on Betty and can make a difference to her care and to really, input to her, or to work with her, or to respect her, to listen to her preferences and to see what she wants. Like, I don't want to be on a mixed bed ward. I want to be in a room with other women. I don't particularly want to see women, but I want to be in a room where I'm with other women. I don't want to be with men at my age, which was one of our preferences, which wasn't respected, and things like that. And then you're interfacing differently with her to try and deliver quality care. But at any point, it's like dominoes, and you all know this. Everything has to happen in a sequence for the next things to happen. So, for example, if she doesn't get registered in time, she hasn't got a medical record number, she can't be on the hospital system, you can't start to interface with her. If she's doesn't have the diagnostics to confirm a hip fracture, which we all know, the student nurse in first year knows it's shortened rotated, we know it's a hip fracture, but we still need the x-ray to confirm it. If that doesn't happen, then the orthopedic team would hit her and come down. If she doesn't have a theatre space, she can't move on then. If she doesn't have a post-op bed, she can't move on. We live with this every day. So value add occurs when things happen in a timely fashion. So Lean is trying to deliver on that value add and to make that happen. And Six Sigma is trying to remove the variation in the system, which doesn't let that happen. If we move on then, what does value add look like from a patient's point of view? Well, these are just some feedback from 35 patients interviewed recently on the cataract pathway, now predominantly over the age of 80. And when we spoke to patients, what does value add look like, or what does non-value look like? What does waste of your time look like? They predominantly spoke about waiting. So, for example, patients were saying, like, they see their GP and then they're referred, so they wait for an OPD appointment, and then there's a big long wait, and then they wait for in the clinic when they get to the clinic, and then they have to wait for a pre-op assessment, and this is all going to happen twice because they're having 2 eyes done. And then they, there's the actual time of the clinics. Patients were saying, why are the clinics at 8 o'clock? I live by myself, I'm in my 80s, 3 eye drops by the time I get there. Why are they at 8 o'clock in the morning? The timeliness of the information and the actual accuracy of the information for visually impaired people, and then the time spent with the clinician, and then the actual wait time for surgery. So that's not value add. That's what non-value add looks like. So there's just an experience of what non-value add looks like for patients. So we're trying to address those with methodologies like Lean and Six Sigma. So how do we make sure that the person stays central in that? So person-centeredness, to quote Brendan McCormick and Tanya McCants, is an approach to practice established through the formation and fostering of healthy relationships between all care providers, service users, and others significant to them in their lives. It talks about personhood, self-determination, and mutual respect and understanding. But person means everybody involved in care. So it's how we treat each other as professionals. And as Mark Graban often says, we often make things better for patients. And I've been a patient myself. I've got 2 family members in the health system at the moment with serious conditions. And I'm living the dream again there. And just to say, the persons there we're talking about are each other as professionals that we work with as well. So how we treat each other, how we work with each other. And we often make things better for patients by making them worse for staff. So we take staff who are already burnt out and busy and tired and fractious and just really at the end of their tether, and we give them more work, which does make things better for patients. But interestingly, it doesn't make things better for staff. So to be person-centered is really important. So we often have seen, if you look at the literature, traditionally improvement happens, but it often makes things worse for the people who are delivering the improvement, who are the staff. And person-centered care was identified in the International Foundation for Integrated Care survey in 2022 as the most important feature of care. And it is the focus of the 2024 survey as well. So a person-centered approach to improvement is really, really important. So we're trying to see, how do we reconcile these concepts of personhood with Lean and Six Sigma, or any methodology really, but particularly we looked at Lean and Six Sigma. We've got to get a result, we've got to get an outcome. How do we do that in a person-centered way to deliver outcomes that patients are involved in determining, that patients have a voice, that there's patient involvement, but also that staff involvement, and have some say in the direction of change as well. So this research really was based around the Centre for Person-Centred Practice Innovation in Queen Margaret University at Edinburgh, and obviously then UCD with the Lean Six Sigma programs we run there, and then the Mater Hospital was very kindly with our first study site, and then the Beacon Hospital was our private hospital study site, and then the Northeast Regional Integrated Eye Care scheme was, I suppose, our first multi-deployment site across 10 sites. And what we wanted to do was, we wanted to look at what would a person-centered model of Lean Six Sigma look like in practice, so we could develop one and to test it in clinical sites. So if we move on then, over 13 months in a review of the literature in Edinburgh, we were able to dissect the literature. We found 4 papers that genuinely spoke about person-centered Lean. There was nothing on Six Sigma. 4 papers internationally. So we knew there was a huge gap in the market, so to speak. There was a huge deficit. And often what Brendan McCormick calls patient-centeredness masquerading as person-centeredness, where you talk about being person-centered, but actually you're only talking about the patients. And I see it the whole time in the literature, read anything, it talks about person-centeredness, but does it mention anybody other than the patient? Of course, patients are, at the end of the day, our ultimate customers, but we have to look after each other as well. Where do we figure into this? Where do staff figure into this as well? So moving on from that then, what we did was we had an idea then from these 13 months of research, what were the synergies and divergences between the methodologies of Lean Six Sigma and person-centered approaches. So we understood those. And then what we did was we took that model, but we sort of parked it for a minute, and we wanted to understand insights that were currently using Lean Six Sigma. What about them? So we use what we call a realist approach. It's a particular research methodology and a philosophy. What about the intervention of Lean Six Sigma worked? Who did it work for? And how? And in what context? And the first context was in acute hospital settings, was where we looked first. And we try to understand that so we can understand have an understanding of whether, to what an extent, and what way Lean Six Sigma worked in the healthcare system. And just to give you an example, we were able to come up with 3, I suppose, pillars, which are no surprise to any of you. So the 3 pillars were Lean Six Sigma as relates to patients, Lean Six Sigma as relates to staff, and Lean Six Sigma as relates to the organization. All integrated and all interwoven, of course, but 3 very different things and different outcomes, and also different expectations and needs as well. And we were able to see that there were 3 key themes in relation to staff when we worked with staff. And the 3 things were the aspects of the organizational culture, no surprise to any of you, that they worked in. The second one was, how receptive was the organization to change? But in particular, we were looking obviously at Lean Six Sigma. How receptive were they to Lean Six Sigma as a change methodology? And most importantly, for me, this was the one that really interested me, was how did staff who were involved in change, how did they see themselves? Did they see themselves as leaders? Did they feel empowered? Did they feel as enablers? Did they feel they were facilitators? Did they feel they were just sort of, if there's a problem, throw it at them and they'll sort it out, which some people expressed? What was it like for them being change agents? And you know that old saying, a prophet's never welcome in their hometown. So we really wanted to explore that. So moving on from that then, what we were able to do was we were able to develop a series of theories, program theories. And what we were able to do, and this is just an example of one theory where basically within the context of hospitals where practitioners were leading on process improvement projects, and they were, within the organization, this was a key finding. The organizations were key. What we found was organizations responded better to improvers who were in-house as opposed to consultancies coming in and doing it for them. They preferred to lead on their own change with people who knew the culture, who knew the systems, who knew the structures, but who were trained in improvement. So that was a big finding. And then what enables staff to engage? Well, we found that staff engagement improvement where they were engaged by staff leading on change within their own organization, who came from within the organization, where results were shared and people were kept informed and involved the whole time. And also an interesting one we found was that, which came up in none of the literature anywhere internationally, was that staff said that one of the things that's never captured in the literature, which we have now captured in the literature, was how they were enabled to involve in change. Was where, say, myself and Juanita were working together, and I said, "Oh, I'd really like to go and do some data collection." And Juanita said, "You go, I'll cover you." This goodwill where we get each other's backs and we actually look out for each other and say, "You go and do what you have to do. You go and do an observation. So you go and interview those patients. I can cover you." That type of goodwill that is and the health service runs on a lot of it, let's be honest, you all know this. That type of goodwill was captured nowhere. So how did we capture that? So by talking to staff and engaging with them. And what we saw was when these contexts were in place, that people were happier in their job, they felt engaged to lead on change, they felt respected as change agents, and they became more critical and creative in their approaches to change. So they would try new things. They wouldn't do the tick box change. They would say, okay, we can lead on this. And interestingly, for us then, we were able to take each of these, and just to say there was multiple of these type of theories, we were able to then ask staff to map those theories to the model of synergy and divergence. And that then enabled us eventually to develop the model, the Lean Six Sigma model. So basically what this model looks at, and the model is in a book form, and there's a link and there's a multiple resource at the end. It comes in a PDF form. If you'd like a hard copy of it, we can mail it out to you. My colleague Vanessa can send it out to you. It was published last year. But the model, basically, this is just, I suppose, a piece of it, but it looks at the synergy. So where is it synergistic? Where it's synergistic is where we're looking for a customer voice, whoever's touching the process, whoever's involved in it, whether they're staff or patients, whoever they are. Where there are observational studies taking place, where there's concepts of respect for person and when staff are empowered. And then quality traverses this. But we also really were aware that there are divergences where they go off in a different direction, where the core values of process improvement methodologies are very outcome-based. What's the return on investment? What were the outcomes? But not looking at what people valued. What were their visions for the service? What was their vision for their own healthcare? And the first principles of improvement methodologies are often about the outcomes, whereas the first principles of person-centered approaches are the people who are involved in the change. And then the key thing that came out was in Lean and Six Sigma, in an industry setting, it talks about standardizing to make things better. And though we must standardize, to have continuity of care, etc., we have to be cognizant that to deliver individualized holistic care and across different specialties, whether it's oncology or whether it's surgery or whatever, that there are different requirements and we can't just have a square peg round hole fit. So that's at a very, very high level. And basically then the model is designed to act as a lens. So it's not a checklist. Basically what it does is if you're involved in change, it poses key questions for you at certain times of your change initiative and asks you to pause and really just reflect, because person-centeredness is not descriptive. It's about being reflective. It gets you to reflect on your own practice. So that's really where it is at that point. So I might just take a breather there on these if there's any questions. I'm on full tilt.
You're absolutely, and you've covered a huge amount in a short space of time. And I know we'll come back to a few more slides in a moment when you've had a chance. I think probably one of the things that really strikes me is the realism, I suppose, in the approach, and the fact even things like mapping your own mother's journey and the insight that gives you in terms of the services. The other thing I suppose that strikes me is that focus on staff. And I'm very conscious, that you've spoken very much about the importance of staff. And from a manager's perspective or a leader's perspective, when you're in healthcare, you sort of feel like if you're focusing on staff, you're going to be perceived to be negligent in your duty in some way. So, like what made you focus on staff rather than the person, the patient?
Yeah, that's a really good question. So thank you for that. That's a really good question, actually. And I might actually, I could sort of address that if you put up the next
Brilliant.
slide.
That'll be great.
Yeah,
Thanks.
great. Yeah, I think that might help me address that. So basically, I suppose there's a couple of things. First of all, so one of the things we find is for the last couple of years since mid-2020 with COVID, we've been doing interviews with staff, and in those interviews with staff, what we have found is that we do 10 questions like every week as part of our white belt, and what we found is that 70% of staff, these are the cumulative figures. We know there's over 200 people interviewed, and we know that 70% of staff come in early, 78% of staff are skipping their lunch or breaks, and 85% of staff end up working late. That's across all disciplines. So we know that staff are already at a breaking point. So asking people to involve in change who already haven't got time to even get their lunch is a no-win. I would tell you to go away and leave me alone, to be honest with you. And I suppose what's important there is to understand the difference between patient-centered care and person-centered care. That staff are, when we looked at this, we broke it into 3 pillars. The first pillar was, as we had staff and patients, and I said, well, I could look at that as part of the PhD, but then at that point, sort of went, yeah, but the patients are being engaged by staff, and it's how the staff use Lean or Six Sigma or model for improvement, how they use that impacts the outcomes, but also how they interact with patients. And then the organization at the end of the day is driven by the engine of the staff. So the organization is depending on the staff to deliver the output. So we thought actually start with staff, and then we'll be able to move to patients and to the organization. But actually 2 further PhDs are currently ongoing. One is looking at the attributes of lean leadership, which is covering the organizational piece. And the second one is looking at the specific contribution of the person-centered Lean Six Sigma model to quality and safety. So Anne-Marie Keown is looking at leadership. She's one of my colleagues, she's PhD student with PhD. with UCD currently, and then Ailish Daly, who's in the Beacon, heading up quality there. She's looking at this contribution to specifically to quality and safety, and that's got a very strong patient ethos in that. So I suppose we hived it up into three manageable manageable parts. But for me, very much it was that focus on staff, because really, at the end of the day, improvement is about giving staff the time to do the things they have to do in the time they have to do it. And I challenge everybody on the chat, many of you are there, hello. How many of you, even if you to put your hand, I don't know if you can put your hands up, how many of you would say, if I asked you to do something, you just don't have the time? Everybody, people are literally just running to keep up. And that's what you're trying to do, is you're trying to create staff the time to involve in change in the first place. Very long-winded answer there. Sorry about that.
No, I think anybody that's on the call will probably resonate with it. And I always use the analogy, you know, the building's on fire and we're here with a bucket at a time, as opposed to sending someone down the road to turn off the gas. You know, it's that sort of sense of what are we doing to sort of, you know, make it easier for ourselves, and we're so caught in it all. So that completely resonates. And I think you can see some stuff coming up in the chat that agrees. So thank you for that.
So this is just an example, I suppose, of slides. This is really, for me, it's a great picture, and I put this up on Twitter one time when there was a dispute going on with pathology and medical scientists to support them, actually. And this is a team of people involved in the Mater Hospital COVID virtual monitoring clinic back in 2020. So we were all told on the Monday, get a virtual clinic up by Friday, and then this team, you've got physios and nurses and, you know, admin and speech language therapists, and there's a whole team of us there. So many of us there, I think there's 8 of us there. I can't count, obviously, 1, 2, 3, 4, 5, 6, 7, 8. Anyway, if you move to the next picture, this is actually the people who are the COVID clinic team. So everybody who's carrying a yellow ball there either works in pathology or phlebotomy, and they're never seen because they're what we call the hidden factory. They're staff who are working in the health service, who aren't front of house, who are making a huge contribution. They were doing the COVID testing and the bloods for the COVID test, but who sees them? They're invisible. They're not valued. So we said we want to take another picture, and now we want to put the people, everybody in the picture who's involved in it. And that was really important for me as well. And then the next thing is that everybody who has an orange there is somebody who's trained in Lean Six Sigma and is a practitioner and can lead on change. So they're supported by people within the team who could help to get that clinic up and running really quickly. And everybody in that team there has at least done the fundamental of improvement, a one-day program. So everybody there is in the headspace for change. So you've got together a team there who are all visible and all want to make a huge change and can do it in a week. So that's why the staff piece is really important. So I think it's a very powerful picture when you think about it, about the hidden factory of people. There's so many people that just aren't seen who are delivering excellent care, but they're not even acknowledged. So I think it's really important. So that's the I suppose, moving on with the staff piece. So just to say, what we've done then is working with UCD and working with QMU in Edinburgh. We have integrated all of this work into a module within our process improvement work in UCD. So we have an entire module on the module. It's an eight section module within our what we call the green belt, and we've integrated that into the curriculum, and it's won awards at different levels around for its work. But basically the key thing is that we're integrating theory into practice. So we're educating people how to use this model, what the model means, and then how to put it into practice in their practice areas. But then we're also getting feedback from them on how it works and doesn't work, which is important. And then we can update the curriculum the whole time. So I think that's really important as well, that we are actually trying to tackle this from an education point of view as well, because one of the big things is education and training. Can I take a breather?
You'll be ready for your lunch after this, Seán Paul.
Definitely be ready for lunch.
You talk about the process improvement, and obviously, you know, process improvement itself is known for getting results. That's why people have done it for such a long time. You follow your process, you get results. If something is going to get results, you know, what's the argument for moving towards person-centered process improvement? You know, what is that added value that it brings?
Okay, actually, and again, I could move to the next slide and might start addressing that. Thanks very much. So I suppose I would say there's two things, and I know Helen Bevins has this, but we said like management by fact and meaningful metrics. So management by fact is when you bring your data, and then meaningful metrics are metrics that actually have some meaning to the people involved. So I suppose let me start with the management by fact. I'll give you a really good example of a story here. there was a colleague of ours who was doing his master's with us. He's working in a service. He was doing, as part of the master's, he was doing an improvement project. And in his improvement project, he was looking at a transplant clinic, heart lung transplant clinic. And that clinic, we'd say, is ran every Thursday and saw 28 patients every Thursday. And at the end of his project, that clinic saw 28 patients. So you're running that clinic, and your data is there, to show that your data would apparently show that, there's no improvement there. Now, I would ask any of you out there again, how many of you have your work judged, and I use the word judged, by volume? How much work you do is judged by the volume of outputs that you have, how many patients you saw, how many files you charted, how many consultations you did, how many prescriptions you wrote, whatever. And are those the metrics to be looking at? So if you're managing by fact, yes, do look at the data, but make sure you're looking at the right data. So in regard to his project, what you should have been looking at there was that before the intervention, patients were spending 40% of their time waiting in the clinic to be seen by a clinician. They were spending about an average of about 8 minutes with the clinician, and they were coming back every 6 weeks. Post his intervention, there were still 28 patients attending the clinic, but post his intervention, patients were spending about 10% of their time waiting. They were spending double the time with the clinician. And because they were spending double the time with the clinician, they were attending every 12 weeks as opposed to every 6 weeks. So what basic thing there is, we were measuring the wrong thing. To measure the improvement, make sure you're measuring the right metrics. It should have been measuring waiting time spent with the clinician, and frequency of attendance. But a manager who only looks at the volume of patients is missing a trick there. So what's what I mean by management, by using your data well. And meaningful metrics are metrics that actually have meaning to somebody. I'll just give you an example of a really good story. So there's a healthcare system in New York that I've had the pleasure of interacting with, Montefiore Healthcare. And they came up with this idea that, they had huge DNAs at their clinics. And they tell you this story themselves. And they decided, the head of improvement there, fantastic, she said, we need to do something for them. So, patients are coming to clinic, and we can see that they're delayed coming to clinic. So what we're going to do is we're going to prioritize patients for this mother and child clinic. It was a pediatric clinic. And we're going to prioritize parking for those mums. So they have basically great parking for the clinic. And they will improve our DNAs because people aren't attending. But it wasn't a meaningful metric at all, because they did what they thought was right. And they did a survey, and people said, yeah, the parking is crap. Pardon my French, being a North Sider there. But the problem was that only some people answered the survey. So what they did was, most mums attending the clinic, it's in New York, were a lower socioeconomic class, and they were bringing their kids on the subway to the clinic. So all they did was create a two-tier system where the people who could afford to drive got free parking, and the people who were coming, who they didn't want to DNA, with the sicker kids and the poorer demographic, who were coming on the metro, were still being late or DNAing. So the metrics have to be meaningful. We have to design metrics that are based on patient need and not what we think they need. So I suppose they would be examples of, like, a really person-centered lens would enable you to think more carefully about those metrics, as opposed to just, tick box metrics, which often, and I see somebody put in the chat here, which I completely agree with you, KPIs are very important. They tell us how we're doing, but they have to be relevant, and we have to understand them. And of course, they're important for performance, but there are other metrics we need to look at as well. And in every single, and I've worked in over 200 improvement projects I've worked on, and the team I work with a fantastic team of people in the matter, I have to say, in the Lean Academy there. We always say, don't forget your customer voice, whether it's patient or staff. What did they say? And it's developing metrics that are based around those voice. And some of you will know, like, critical quality tools enable you, which is a very person-centered tool, enables you to develop meaningful metrics as well. Anyway, sorry, again, a big long answer. I get very passionate. Sorry, Juanita.
No, I think it's really helpful, and when you start to pull it apart, it is the fundamentals. And we sometimes, we are very much an organization that's driven by metrics, because there's the desire to have as much information as possible about everything. But there is the bit about the right information. And I have a particular bugbear about collecting the same information in 5 different ways that give 5 different answers, but don't actually answer the question that you need answered. So there's something about, what information are we collecting? Where is it going to? And then, as somebody put into the chat there, what feedback are we getting on the information we're actually capturing? So where is that feedback back in to say, well, actually, this is what it looks like, and this is the impact of it.
Yeah.
There's a few more questions coming in the chat. I don't know, do you want to take one now, or do you want to go on with a few more slides? What would you like?
I just might have only a couple more slides to do, and then I'd be happy
Brilliant.
to take. Yeah, great.
Great.
Thanks very
Thanks,
much.
thanks, Seán Paul.
No problem, no problem. So just to say, this is just it's adapted from the ladder of citizen participation. It's around since 1969, but engaging with patients or with staff, it's a very powerful tool to use. And basically, there's a couple of ways to look at this. There's what we see as different ways of engagement. So we often, are like manipulating. I don't like to use the word, but if you look at the model here, patients do not engage in planning or conducting the improvement, but enable the improvement. So we sort of manipulate them to a place where we need them to be, to look at or to look at and we have like I suppose tokenistic involvement in a way. That can we can have some consultation or some informing of patients, say for example involving in projects. But what you really want to do is you want to move on. If you move up the ladder, and it'll be in the slides for you there to have a look at, you're trying to, I've just adapted the model on the left as to how I use it, where I'm engaging with patients. But you can see you're trying to move to more of a partnership model where there's delegated power, where there's patient control. And this could be something like, where we've worked on projects where, we've not only asked patients to involve in deciding what the key metrics are, but asking patients to collect the data and to analyze the data and then to feed back to us what the data means. So it's really meaningful. So that you're actually part of your project team, and which is obviously what PPI is all about. So that's just something really to highlight there. But if we move to the next slide, and then I think I'll be finished. This is just, I think, is important to point out that very much the Lean Six Sigma model is designed to work in that regard, that you're trying to move to a more empowering way, to move, whether your customers, whether they're staff or patients, to move them up that ladder into an area where they have power, where there's partnership, where rather than, I'm sounding very Catholic now, but rather than that be it done unto me according to thy word, whereas people come in and start doing change onto you, that actually, no, I don't want that particular change. I want to be consulted. I want to be involved. I want to have a voice. I want to lead on the change, and I want to decide the direction of change. Now, obviously, that takes time, which is why freeing up staff time in the first place and focusing on staff is creating the time for that change. So, really, it's about enabling us to collaborate with patients and staff in a very inclusive, participative manner to co-design the solutions that improve outcomes, yes, but also elevate patients and staff experiences of change. And I think that's really important. So I think that's more or less. I'm very happy to take questions now, Anita. Please, it'd be great.
Yeah, no, and thank you so much again for all of that. Like it's so insightful, really, and I think when you begin to pull it apart, it's the practical elements. And there's a question in here from Aileen, and said, given what you've learned from this really interesting research, how would you go about starting a new quality improvement initiative from this perspective? So somebody that has never, maybe this is the first time they've heard about it, where should they start, or what can they do to get started?
Yeah. So thanks, Aileen. So I can only speak really supposed to because I teach and educate in Lean and Six Sigma as improvement methodologies. It doesn't really matter what one you use, but what I would say to you is go to a process, get some process improvement, even in induction, dip your toe in, do like a white belt or something like that. Just do something, a day's induction even, and see what you think of it, because there's lots of different methodologies. So particular methodology may not appeal to you. I particularly just like Lean Six Sigma because I come from a theatre background, surgery all my career, and I like a thing for every place and a place for everything. It's very organized, very logical. It puts shape on chaos, so that's why I particularly like that.
Yes.
And it does have a lot of synergy with these voice to customer. So I suppose that would be the first thing. The second thing is, read, for example, read Mark Graban's Lean Hospitals, an easy read about, and what's lovely about his Lean, that book, and why I was very first attracted to that book years ago, was he talks about improving patient outcomes and staff satisfaction. It was the first book I'd seen that said, oh, actually, the staff are actually have to be satisfied with the change. God, that's really interesting. So, there's a couple of things you could look at there. There's a number, as Monique said, the HCC have a number of resources as well, but I would really urge any of you. I did my I suppose my black belt through industry. I did my green belt through healthcare, and I was in a rush, so I did my black belt through industry, and I spent my whole time going, what would that look like through healthcare? So I'd advise you to do improvement with a healthcare slant, because it's very hard to translate an industrial into, because it's different, because patients aren't product, and you're dealing with a different thing totally. So, and just to say, and the last thing is the model is up there for you to have a look at, and it's quite easy access. But within the model, there's about 4 pages. There's about 60 references, and any of those papers or books within that will be an interesting read. And also there's links to key papers that inform the model as well. There's about 5 papers there, so that you can just use the QR code for that as well. But there's and there's lots of things. As Mark Rabin has a really good podcast. I just saw Kira. Hi Kira, good to see you. Good podcast there as well. So there's lots of resources, I think.
That's it. It's the time, as I say. I definitely think looking at the small booklet that you've done, it's really concise, it's really compact, and there's a lot of really helpful information there. So if you haven't downloaded it already, I know Chris has put the link into the chat earlier on, so have a look at that as well, because I do think that, as you said, the resources in that, but even that in itself, there's a huge amount in it to get started and to start just even to think about it. We're often asked by staff for guidance on what engages and disengages people. And some of it is very self-explanatory. You think about, well, what does it mean for me? And you think about 5 people, and they'll all have different things that pull them in or push them away from something. But, from your learning around the research, what was important in terms of those factors for engagement?
I suppose, I say, first of all, I suppose the research definitely, but I think is lived experience as well. And for me, the lived experience, I'm sure many of you experiences, when I'm going to engage in any change, and this would be my tip to anybody, when you're going to engage with any change, remember, if I was asking Juanita to change a particular, like when it's new department, first of all, staff will only change if they see the need for change. So if people don't understand that change needs to happen, well, then there's no point going there. The research has shown, 2 of the big themes that turned up in my research over the 5 years was, and it wasn't in Irish context, but it's transferable learning, was when people went into an organization and they were told, and they said, oh, I can make things, where I used to work, we had a really great way of doing that. And the 2 things to meet are, we tried it that way, we tried that before, it didn't work, we've always done it this way. It's very hard if you're new, or if you don't feel empowered or in a safe place to be that person. And the other thing is as well, so that's from the research. The other thing is just from learning is that if I want Juanita and her team to involve in change, if I can't answer for her 2 key questions that she needs to understand, what's in it for me and what's against my interest. And my advice to any of you is, if you're going to engage with any customer or even your own team or colleagues, and you don't understand what's in it for them, that you can say to them, well, what's in it for you is this, and what's against their interest. So for example, when I go into work with teams, and the team I work with, we go into work with teams and say, why should we engage in this change? So what's in it for you is that this will mean that your staff will get their lunch breaks. Putting the staff in there, you might get off on time. From an organization point of view, it might reduce overtime rates. Your patients will get to spend longer with you. You'll be able to spend more time with the acute patients. It should improve your patient outcomes. Hopefully, this is the hypothesis. It could solve a lot of your problems. It could improve staff morale. And we found a lot of the time people come to say to us that they don't talk about change, just say our morale is really bad in the team. And actually, that's what they come to you with, the problem. And then the next thing is, what's against your interest? Well, actually, there's really nothing against your interest at the moment. What we need you to let us in and work with us and share your data and talk to us and tell us your stories and let us, do observational studies and just let us in. And what is against your interest, being honest, is you may have to change some things, but let's see where we go. At least people then are starting to, you're being honest with them up front. But there, I think, what's in it for me, what's against my interest. And if you can't have an understanding of that before you engage, or at least want to understand that, well, then the change won't happen.
Okay. I think that's really helpful. And I think those 2 questions, actually, they provide a really key focal point, because without knowing those things, you're at nothing. And sometimes as well, not assuming what those might be, because, for us, definitely with some of the work that we've done, the things that we thought might be an actual barrier or something that we thought might be a negative for staff weren't a big issue, and something totally random, when I say random, something totally different was actually the challenge. There's a question here in terms of the metrics. You mentioned metrics about getting the patient voice,
Oh, yes.
and they were wondering what those metrics were.
Yes, so thanks for that question. So in Six Sigma and Lean, we use what we call the voice to customer. So when you often say so basically you say what do people want, and you ask people what they need and what they want, and people obviously articulate what they need. And then, but one of the key things is challenges we face is how do you translate those needs into something that's quantifiable. So there's a tool that's a Six Sigma tool called the Critical Quality tool, and actually there's an example of it in the model from a very good project that my colleague Karen Connolly carried out. She's a physiotherapist who now leads. She's a service lead, improvement lead, and Karen used that in stroke therapy to try and get more time for patients who had a stroke to have stroke therapy. And that I've given that example in the book it's published. And that enables you to take what people have said and say, okay, that's the need. What's the driver that's required to deliver on that need? And how do we measure whether that driver works or doesn't work? And that's where you're using tools, not in a tool-based manner, but as a framework. So I love that tool because it basically translates a voice into something you can measure.
Yeah.
So it's in the book actually if you want to have a look, but it's a really useful tool. And that's using tools not just as a tick box. Like, it drives me mad when people say things like, I'll be honest with you, and like, oh yes, what you call it, I spoke to the patient's tick. Okay, yeah, but that doesn't mean you're finished. That's just you spoken to patients. That's grand. And the second thing would be something like, I heard one time somebody saying, what you call it, well, the nurses don't know. And I said, that's interesting. How do you know the nurses don't know? Well, they don't know, but have you engaged with them? No. Have you spoken to them? No. Have you surveyed them? No. Have you done a focus group? No. So you don't know. I said, so you're making a huge assumption there that nurses don't know. I said, you can't assume anything in change. And that's probably what's in it for me, what's against my interest. And never assume, because you just can't assume anything in change.
No, you really can't. Just on that, we talk about change and you talk about process improvement, and sometimes there's a perception then that it becomes this add-on, something else that we have to do on top of it. Like how important, or have you suggestions for how you can make the process improvement that's person-centered become part of how we actually work, and that it isn't this extra thing on the side that somebody then moves on and then it's lost?
Yeah, I think that's a really good question, and thank you for that. So I think what you do is what you call it. If you don't have to work in a team, you as an individual, it's how you work as an individual. So the model is very much developed that if you use process improvement methodologies, that you can use those questions to reflect yourself. So although we have it in use in multiple sites, there are individuals actually just using it who just taking the model and use it to sort of direct their own work as well. So I would say to you, it's important to make it business as usual. It's how we work around here. And a really good example is, and the Mater Hospital, I won't say, like, we still have patients and trials and all that, but if you look at how staff work there as a team in the last 10 years since we introduced the whole concept of working in a lean way and then morphed it into a person-centered way. One of my colleagues had left. She went to England. She was physiotherapy. She went and she came back, having worked in the UK for a number of years. And she said she noticed a palpable change in the organisation. So if you look at that example I gave you earlier of the COVID clinic, on a Monday, set up a clinic by Friday. Now I know everybody was working at full tilt anyway, but there was never really any panic about it. We're going to process map that. We'll have a process map for everything. We'll have an algorithm for everything. So that enabled us to say, have we got a process map for social inclusion patients? Have we got a process map for patients who have no accommodation? Have we for the traveller community? We were just mapping it out. We were all talking, not jargon, but we were all talking improvement. We all were in a very can-do place. So it enabled you to get into that space where, as opposed to, oh, this is impossible, to say, okay, let's just get stuck in.
Okay.
So you make it business as usual.
Yeah. It's interesting, the culture in every single organization is different. And I know Paul has a question in there on the culture that might need to be overcome from an organizational perspective to make this sustain. And I know you're doing this within 7 other different countries. Do you think that the culture is sufficiently different in different areas, or do you see the same things coming up again?
That's I keep saying it's a really good question, but these are great questions. Yeah, I do see the same things coming up. The same issues exist. Wherever we speak, you can see, wherever we're working, you can see staff nodding and saying, yeah, these are the same issues. So for example, so Saskatchewan was the biggest lean deployment internationally ever. And they did the entire state of Saskatchewan. And they
Wow.
went about it in such a non-person centered way that they ended up having the unions in. It became a union issue. People refused to, and they were so badly burnt. And now we're working with people like in Alberta and other centres in Canada who've come to us and said, how do you do improvement? And we said, well, we do this person. And they were going, God, if we'd done it like that in the beginning.
Would have been
But it's
different.
great for us to, it's great, but so there, yes, the culture piece there, but it's when it's this, it's when it's this, this is what you're doing. And this is what we're, and it's because this is how we're going to do it. And there's no staff engagement or staff buy-in or voice at all. Well, then obviously, if those staff are the arbiters of excellent patient care, which is why I spend a lot of my time focusing on the staff, well, then the care is going to suffer as well. That's common sense, I mean, at the end of the day, lean is, a lot of it is common sense. It is common sense.
Yeah, it's the pause for the common sense, and is my common sense the same as someone else's? Is the question. But sometimes, there is a question in here from Eugenie, just wondering, how does it integrate with the current focus on human factors?
It integrates very well, Eugene. It's not actually, interestingly, at our symposium last year in Crow Park, we have an annual symposium. We had sections on human factors and lean and person-centeredness. So I would work with, say, for example, designers from NCAD in the matter, not so much myself, but the team there as well. And the designers have all done our white belt, and they'd all be trained in human factors. So there's an awful lot of synergy across those as well. So it's not a huge leap to integrate them.
Okay. And we're just coming close to time. So I'm conscious that, we talk about the profit in their own land. You spoke about that earlier on. There's obviously a lot of really good work happening within Ireland at the moment. What would you say to people about sharing that knowledge, within Ireland and further afield?
Oh, I'd say get your work into scientific posters. Get yourself to every conference you can get yourself to. Get yourself published. I mean, when we started 10 years ago, we were using case studies from Canada, the States, the UK, and Scandinavia, and now we've about 50 Irish publications. We've over, not we, I mean, like in Ireland, in the field of Lean and Six Sigma, we're developing a lot in the person-centered. The person-centered work is all coming out. Lean Six Sigma is all coming out of Ireland at the moment, and we've over nearly 300 case studies. So we can take our learning. We can take our learning internationally as well. So, that's how we've been able to do it. So I'd say to you, but, really, I think Irish people are terrible. And with no offense to any of us, we hide our light under a bushel. There's great work going on, but nobody knows about it. So guys, you need to get out there and actually say, look, we're good at what we do. It's okay to be proud of your work. It's not bragging. It's actually being proud of yourselves and saying, it's self-worth. It's not. It's self-worth.
And it's important, I think, as well, in the sense, if it could save somebody months and months of research or going down a pathway that's going to, there's learning from somewhere else. I think it's nearly incumbent upon us to do it. Just before we come to the end, is there anything you'd like to leave the participants with?
I suppose at the end of the day, I suppose really. There are times, like, when you will be like in COVID, we had to sort of revert to that command and control. But even in that, don't lose sight of your person-centeredness. So, for example, I mentioned my colleague Maria Creed. She's a fantastic Lean Six Sigma black belt. She's an operations manager. She used to work with us, and when we were doing the COVID clinic, we used to have do the off duty. Now, Maria is a pharmacist by background. She's going, I don't want to be doing off duty. I don't want to be doing off duty. Like, I hadn't worked clinically for years, and we were going. So what we did was we said, okay, you know what we're going to do? We're going to put the off duty out there, and we're going to let people fill in when they can work. And there was not one day during the whole of COVID that was not filled in, because yes, we were using lean principles to run a clinic and to free up beds and all that, but we were also being cognizant of respectful of each other and saying people can fill it in themselves. They're not children, and that there was never a day that clinic wasn't covered in the whole time during COVID.
Yeah.
So I think don't forget you can still be person-centered even under pressure.
That's it. The autonomy, I think, is huge and it's key. Just to say thank you so much for your time and sharing the knowledge and expertise that you have. It's a huge positive for us to have you here on QPS TalkTime. We really appreciate it. And
thank you so much.
yeah,
I'm delighted.
Thank you so much, and hopefully people will be able to access the resources again. It's lovely to see messages coming up that you're inspiring, Seán Paul. So just so thanks again, everybody.
We're going for a cup of coffee. I'm expiring.
No, that's it now. What we'll do is we'll pop up the final few slides, and thanks again for everybody for staying on just to the end. So thanks for that. So just as we come to the very end of it, just to say, in terms of our social media platforms, you can follow all of us on the at QPS TalkTime at National QPS. You can see this video. A few people have asked where can you follow us on YouTube. You'll get it at National QPS, and you'll find all of our QPS TalkTimes there. So for any of your colleagues that you think might be interested in this, they'll be able to see it in a few days' time. And you can also follow us on LinkedIn. There's 2 new podcast episodes, Could It Be Sepsis and Reducing and Managing Sepsis. The Could It Be Sepsis is particularly for patients, family, carers, anybody that you think that's out there that might be interested, yourself with your own patient or carer hat on, or parents. And then the Reducing and Managing Sepsis in particular for healthcare professionals. So 2 different podcasts, 2 different audiences. You can listen to the 2 of them. We never mind anybody who listens to both, but just to keep it in mind, they're really useful guidance, and in particular at the moment it's so topical, because they're we're learning the whole time, and we're learning that people don't necessarily know the signs and symptoms. Thanks again, everyone. We hope you have a lovely afternoon. We'll see you in 2 weeks' time.